Hi everyone, I welcome you to the World Headache Society's weekend lecture series. Thank you so much for joining on a lovely Sunday morning or evening, whichever part of the world you're from. Some basic introductions before we begin. I would request everyone to keep yourselves on mute so there are no distractions during the progress of the lecture. And you can have your videos on as well so that we can see your beautiful faces. There will be a question and answer session in the end. You can type your questions in the chat box or you can directly ask to our esteemed speaker, whom I'm delighted to introduce, Dr. Abouch Krymchantowski. He has a master's degree and PhD in neurology with a thesis specific in headache. He is a fellow of the American Headache Society and he is a director and founder of the Headache Center of Rio de Janeiro. And he is the creator of Rounds in the Headache. So he has extensive experience in headache medicine, and we are delighted that he has joined today so that he can impart us with his experience and knowledge. We are honored to have you here, Dr. Krymchantowski, and without further ado, I hand it over to you.
Thank you very much, Dr. Sofia Hussaini, our colleague from the World Headache Society. And she is talking today from New Jersey. She's studying in New Jersey. So it's an honor for me to be talking to you today because there are my colleagues from Brazil. I will speak a little bit slower. And at the time of the questions, if anyone wants to make a question in Portuguese, I will try to translate it. So I start inviting you all to the Brazilian Symposium of Headache Update that will be held on August the 8th. Will be one Friday all day long, totally online, 100% online, with the best lecturers in Brazil and in the world as well. We still have like 21 places available. I also want to invite all of you, my colleagues from India, from the World Headache Society, to join, if they want, the Rounds in Headache, which we do like every two Tuesdays, and everyone is welcome. Just let me know, sending me a message that I will add you to the group and you will receive the link to participate. So I have to remind you, before we start, that medication overuse headache is a secondary headache disorder. It happens in colleagues with primary headaches, in people, in sufferers with primary headache disorders. And therefore, medication overuse headache is not a primary headache disorder. It's a secondary happening in someone who already have a primary headache disorder. I had the honor of being one of the 8 members, including Dr. Ravi Shankar from India, who wrote this sub-item of the current International Headache Classification. So medication overuse headache, in order to be classified, in order to be defined, has to show a close temporal relationship with the exposure of the suspension of the use of the offending medication, usually and mostly medications used to treat headache attacks. I also want to call your attention, especially for those who are in countries where triptans can be purchased, triptans can be used without a prescription. In the recent years, I could say a decade or so, most of the patients with medication overuse headache, especially migraineurs, are overusing triptans. It doesn't happen in countries where triptans cannot be purchased without a medical prescription. So the realities are different, especially because of facilities or difficulties to get the medication which is being overused. I also want you to remember that every primary headache sufferer, including tension type headache sufferers, new daily persistent headache sufferers, and even cluster headache sufferers, can have medication overuse headache. We all know that most of the patients are migraineurs who develop through the time this secondary disorder. But don't forget, cluster headache, tension type headache sufferers, new daily persistent headache sufferers can and will develop medication overuse headache if excessively using or overusing their medication. Usually, these patients have also psychiatric comorbidities, and we all know about anxiety and depression, but don't forget there are others to be thought as well. In addition, because of the problems with these patients, most are seen, are categorized as intractable headache patients, which are not. I also want to remember that the definition and the diagnosis of medication overuse headache have to include an excessive frequency of usage, and depending on the class of medication that has been used, like opioids or simple analgesics in the other extreme of the group of medications, the definition changes. So if you overuse ergots or opioids or barbiturates, it's 8 days per month is enough to classify the patient as medication overuse headache sufferer. On the other hand, if you overuse just a simple analgesic or a combination of analgesics and caffeine, the number of the days becomes different, 10 or 15. Don't forget, the patient with medication overuse headache is always an interaction between a susceptible patient, someone who has a primary headache disorder, with one or more symptomatic medications overused. What about the prevalence? Is this a common disorder? If we look at the general population, we will see that from 1 to 2% of the general population have medication overuse headache. But if we go to a community sample, like migraineurs, for example, it varies a lot from 32 up to 75%. But if we are working and accompanying the routine of a tertiary center, we will see that medication overuse sufferers can reach up to 80-90%. In the headache center of Rio, for example, there are some times of the year that 85% of our first-time patients are medication overuse headache sufferers. What about pathophysiology? Are there mechanisms already linked to medication overuse headache? It seems so. Since the problem, the downregulation, the incompetence of the descending inhibitory pain, central pain modulations, up to genetic alterations and alterations in density and function of postsynaptic neurons in serotonergic or noradrenergic system, up to volume alterations, including gray matter, either a reduction in volume, like in the anterior cingulate cortex, up to an increase in volume of the periaqueductal gray, passing through possible immunological alterations. we have been seeing during the last years many mechanisms that are clearly or not so clearly linked to the pathophysiological mechanisms in medication overuse headache. It seems complicated. It seems confusing, but it is. In reality, it is very complicated and confusing. Understand structures and neural circuits that are linked to these patients. And this is a scheme very nicely done by Mesuda Shina's group, which shows that the problems start in periphery. The C and A delta fibers become pronoceceptive, putting upwards more stimuli that will increase. That will increase. I have to change something. One moment, please, because I will try to change the way. Just 1 second, people. So my slides were not being presented. Let me try now. The slides were not advancing, right?
Yes, we could see the screen, but it wasn't advancing.
Let me see now. Now it is. So I was talking about the prevalence, I was talking about the classification, I was talking about the fact that triptan overuse is very common today. The primary headache disorders are the patients with medication overuse headache. I was talking about the definition, the diagnosis that includes clearly the frequency of usage going from 2 days a week ergots and barbiturates to 15 days a week, 50 days a month of simple analgesics, and interaction, the prevalence, the mechanisms, and now we reached where I was. This scheme, nicely done by Mesuda Shina, shows how difficult, how problematic is to understand these patients. We see that there are, since the periphery, an increasing stimuli going upwards up to the cortex, and we have the deficiency in downstream modulation, the PEG and the rostroventral medulla, in terms of putting an obstacle in the nociceptive inputs that go forward. But what you have to understand, although very complicated, is the patients with medication overuse headache have different neurocircuits, different mechanisms involved in this pathology. And what we see as well as when the patient that has to have a primary headache disorder start to present medication overuse headache, the patient loses characteristics, typical features of migraine, for example, associated features, pulsatile pain, unilateral pain, and start gradually to present a more frequent headache, reaching daily or near daily headache, which loses characteristics of migraine and becomes to present a diffuse, a holocranial, a pressure type pain, mild to moderate, and in up to 8 or more days per month, the patient starts to present full-blown migraine attacks, typical migraine attacks. Commonly, medication overuse patients have to be awakened up in the middle of the night in order to get more medication to relieve the escalation of the pain. I also have to remind you that patients with medication overuse headache have psychiatric comorbidities. We all know about anxiety, depression, bipolar disease. We all know about this. But sometimes we forget, especially among the patients with personality disorders, that these are our biggest obstacles to adherence and to a good outcome presentation of our treatment. The first person who demonstrated this was Carla Givu in Rio, a neurologist, my wife, who presented that most of the patients that do not do well with that treatment are medication overuse headache sufferers with personality disorders. What about treatment? Something I also have to remind you, we cannot be naive and believe that the same applies to all of the realities. It doesn't. Patients from Brazil, for example, are different between those going to the public free of charge health care to those from the private centers. Patients from India have a complete different reality. Patients from the United States, the money-driven medical practice in the United States, the opioid overusers in the United States, they are completely different from those patients from Europe, for example. The laissez-faire, the tranquility of the socialized medicine in Europe, where our colleagues use monotherapy. So the different realities make the treatment, the approach to medication overuse headache completely different all over the world. But some things are common. Some approaches are the same. And I suggest this review, which was performed and published by us a few years ago, which has a lot of comprehensive approaches, regardless of what you wear. However, what I have to tell you and make you remember when you see your patients is that some crucial points do compose the treatment for medication overuse headache. First, we have to give real expectations to the patients. We have to educate them that they will not be cured, they will not be with no pain at all. In addition, the patients have to start any program of physical activity, even walking fast 4 days a week. In addition, all the patients have to withdraw, if not withdraw completely, to reduce, despite of recent controversies, they have to reduce the intake of symptomatic medication. There are the pharmacological treatments, either with biological therapies or not, and the patients will benefit regardless of where they are in the world. They will benefit with accessory psychotherapy. And I have to emphasize this. I know that not everyone agrees, but I have to emphasize that if you don't stop the overused medications, you won't have a good outcome with most of your patients. And we have been showing this through the time. If you look at this graphics, we will see that between and among 150 patients that we approached, withdrawing, initiating prevention, most reduced their frequency over weeks. We also showed this recently among 149 patients who were overusers of different kinds of medication. If we do the right thing, withdrawing, starting the prevention, regardless of what we use, anyone can use whatever they know what to use. Through the weeks and with the correct treatment, the frequency will decrease even along months. And something I have to emphasize here, I understand that most of our colleagues like Botox for chronic migraineurs, and Botox is approved for chronic migraine. However, chronic migraine and medication overuse headache do not benefit with the use of Botox. If you add Botox to the withdrawal scheme of treatment, it will not render more benefit when you compare to the withdrawal alone. And until recently, there was no doubt regarding the necessity of detoxifying the patients at the beginning of the treatment. But from the 5 years ago on, when anti-CGRP therapies became available, we started to believe that possibly with anti-CGRP therapies and monoclonal antibodies, we didn't really need to withdraw. This is not my opinion. Okay, my opinion is that we need to withdraw despite of the therapy we believe. But recently, we have to acknowledge that some studies have been showing, demonstrating that, for example, using erenumab, galcanezumab, which is better than erenumab, and even other monoclonal antibodies for populations of chronic migraineurs with medication overuse headache, we see a good outcome. In 3 months, we will see that most of these patients will have a headache reduction, a clear headache reduction. And some studies have been describing as well that the pattern of overuse gradually going back to the pattern of episodic use of symptomatic medication has been clearly demonstrated with anti-CGRP therapies, with the exception of simple analgesics. Look how interesting is this fact. When the patient overuses ergots, triptans, combination of analgesics with caffeine, non-steroid or anti-inflammatory drugs, when they use monoclonal antibodies anti-CGRP, the studies have been showing a gradual decreasing frequency of the headache and of the overuse. But it doesn't happen with simple analgesics. Those who overuse aspirin, paracetamol, and so on, they may not respond so well to anti-CGRP monoclonal. But it's a fact that if we withdraw, if we educate the patient and add a monoclonal antibody, we see very good performances, as we demonstrated as well. If you get a population of medication overuse headache sufferers, withdraw, start the prevention you choose. Doesn't matter which it is. Topiramate, antidepressants, beta blockers, whatever, combinations. But if you add a monoclonal antibody, regardless of what you choose, each one you choose, you will see higher reduction in headache frequency compared to those that didn't add the monoclonal antibody. And we also showed that doesn't matter which monoclonal antibody you choose. What matters is you withdraw, start the prevention, and add a monoclonal antibody, the patient will have a headache frequency reduction more clear and through the time, as we recently demonstrated over 5 years, that adding an anti-CGRP therapy to the treatment scheme will render a higher benefit. However, I also have to acknowledge and to show you, as an impartial presenter that I try to be, that not everyone agrees with the same thing. In this group, this study was coordinated by my colleague Todd Sweat. If you don't reduce the frequency of intake of symptomatic medications and you compare to patients that you do this reduction, you don't see differences. I'm sorry, but I don't think it's possible. I don't see this clearly in my practice, which is now 38 years old. I have been dealing with these patients. So even though this study suggested this, I don't agree with their group. What I mostly do and agree is with this group represented here by the Danish Headache Center people, commanded by Rigmor Jensen in terms of medication overuse headache patients, who demonstrated clearly, if we compare different strategies, the one that will be most effective is to interrupt medication overuse, to start the prevention, and to give the right education to the patient. These patients are those who perform better in terms of headache treatment. They have a clear reduction in headache days, in migraine days, in pain intensity or severity, and as a consequence, in consumption of headache medications. Perhaps with dependency behavior problematic patients, we will have complications in terms of adherence. We know that. We know that psychiatric comorbidities do impair what we want for devolution. And what about GPANs? Are GPANs really good for making these patients to reduce medication overuse and reduce the frequency of the headache? It seems so. We all are acquiring medical expertise, clinical experience using the GPANs in the recent years. GPANs seem to really reduce headache frequency and the overuse of medication. And recently we have a published paper comparing atogepant daily use with rimegepant alternate daily use. So which one is better to reduce the frequency of headache and the medication overuse? It seems that according to this study that was carried out by Cristina Tassorelli's group, that the monthly headache days, migraine days, symptomatic medication overuse, and quality of life measures is decreased clearly with the atogepant compared to rimegepant. So, in conclusion, what I have to tell you that there is a consensus. Let's say that removing that paper from Todd Sweat and group, removing that, there is a consensus about withdrawing overused medications. On the other hand, there is no consensus of which is better for the patient, to start immediately prevention, to choose traditional pharmacological agents, to start an anti-CGRP therapy, to combine as I do. So there is no consensus regarding this, but the success rate is very high, even knowing that there is relapse among some patients. especially those with dependence behavior. But we have to remember that the prognostic is very good, especially if we use a multidisciplinary approach. And the better would be to prevent this situation, giving information and the right education to the patient. And I will finish reminding you that the real refractory headache patient is not the one badly treated, the one who spent a fortune doing Botox many times and didn't get better. It's not the intractable headache patient. It's not the patient with very serious psychiatric comorbidity. It's not the patient still with medication overuse headache. The real refractory patient is the patient who we do everything correct and he didn't improve. So I go back to the beginning just to do again my invitation that you didn't see because I didn't advance my slides. I have to acknowledge and thank you for the presence and invite all of you to the Brazilian Headache Symposium, 100% online on August the 8th with some of the best in Brazil. Who is interested, please let me know. And invite you for the rounds in headache that we do 2 Tuesdays per month, and having been gathering the best Brazilian physicians. So I finished. Thank you very much, saying that it's my pleasure to be here and giving back to Sophia. I'm sorry about the problem with the slides at the beginning, but I believe it was corrected. Thank you, my dear.
Thank you so much, Dr. Krymchantowski. This was an amazing presentation, very comprehensive and very detailed about the different types and pathogenesis and how to manage. We are delighted by and thanks from the World Headache Society that we could have you here and learn from you. Thank you so much. And now I'd like to open the platform for questions from our audiences. Please feel free to type in the chat box your question. I can relate to Dr. Krymchantowski, and also you can unmute yourselves and ask the question by yourselves.
And let me just say in Portuguese to my colleagues that are
Hey,
here.
just a comment.
Good.
My congratulations, my professor. You are excellent in Portuguese and even in English. Excellent didactic. My respect to you.
Thank you, my friend. You are my friend. This is Dr. Jaime Olavo, one of the best specialists in headache and pain in Brazil. Have a lot of tradition. What I would like, thank you, Jaime. What I would like to say in Portuguese or in Spanish, I see that Marília Tereza Reis is here. Welcome, my dear. Se alguém quiser fazer uma pergunta em português, if someone wants to make a question in Portuguese, we can translate for everyone, our colleagues from all over the world. Thank you.
Thank you. The first question I have, which is posted in the chat box, is what is the criteria for MOH? And when exactly do you plan to start TGRP antibodies?
Okay. The criteria are clearly defined. 8 sub-item 8.2 at the current version of the International Classification of Headache Disorders. I was one of those who wrote this criteria, and it says clearly that the headache has to be present in 15 or more days per month and have to gradually develop in the presence of exposure for at least 3 months, and the criteria for overuse varies with the class of medication. For example, if you have a headache once in a while, primary headache, doesn't matter the type of the primary headache, and you start using at least 2 days a week ergots, or at least 15 days a month simple analgesics, and your headache starts gradually to become more frequent, reaching 15 days per month or higher. For at least 3 months, we have medication overuse headache. If you want to go further and classify medication overuse headache and chronic migraine, you have to have at least 8 days per month with full-blown typical migraine attacks. But it may be difficult for tension type headache because tension type headache looks like the same clinical presentation of medication overuse headache. And I saw in my life, most of you probably the same, saw the double acquired, the double, let's say, presented, gifted patients, my God, with such a double suffering, migraineurs who have cluster headache. So the patients take triptans for cluster headache every day. If they are doubly gifted with migraine as well, they will develop medication overuse headache because of the migraine. But there are reports from cluster headache patients who also have medication overuse headache. So the criteria of the headache has its features, and the criteria for medication overuse headache and medication overuse also have its specific characteristic of features. The second question is when to start an anti-CGRP option, medication, right? Well, I know that the realities are different. It depends on where you are practicing. Let me give you the example of Brazil. Brazil is very big, has two different systems, the public, where the patients don't pay, and the private. In the public system, regardless of my desire of initiating an anti-CGRP therapy, I would not do it because the patient will be unable to purchase, to get the medication, even if they are insured by a private firm, a private convênio, as we say in Brazil. They will have problems to acquire, to purchase, to use a monoclonal antibody. On the other hand, if the patient is already in a private system, have the money to get this medication, I will start immediately. If you take a look, the guidelines, the current guidelines or statement position of the American Headache Society, monoclonal antibodies and now the GLP-1s are indeed the first option to treat migraine patients, not only chronic migraine. On the other hand, don't try Botox to these patients because it won't happen to the patient. Even if the patient have chronic migraine and medication overuse headache, it will not happen, as well as blockades. It will not happen to patients. What I do, based on 38 years in clinical experience devoted to headache patients only, I start a traditional pharmacological agent and I start a monoclonal antibody for the same patients. Of course, the patient have to be able to get the medication, otherwise won't. So depending on the reality you are, I don't know about India. I know that India is a socialized medicine system, right? But there are private physicians as well. Depending on the reality, you can start from the beginning an anti-CGRP therapy.
Thank you so much for that. I believe one of the audience
What
have a
would you
question for
say,
us.
Dr. Sophia, what would you say in patients from the United States? I know that there is no public system. I know that everything is charged. I know that most patients have insurance. So, what would you do with a patient with this diagnosis and you know about the anti-CGRP therapies?
Well, as you mentioned, insurance becomes a big problem. It's only after the approval of insurance is when we'll be able to prescribe the medication, and they will have to finish the other categories of medication taken for us to prescribe.
So, they have to fail before in
Yes,
some categories of medication, right?
yes.
And also, I would like to know, in order to prescribe an anti-CGRP therapy, do you have to be someone, a doctor, with some specific specialization, specific formation, or every physician, as in Brazil, every physician can prescribe an anti-CGRP therapy?
I'm unsure about that. I'll have to check with others. I'm sorry.
Good. What about in India? Can someone tell me what happens in India regarding the anti-CGRP therapies? Is there any colleague from India that could let me know
Hello,
what
sir.
do you
Good evening,
do?
sir. Hello. Good evening, sir. I'm Dr. Pooja from Bangalore, sir. Bangalore in India. So I work in a government hospital, sir. So I can tell you, in the government sector, uh, we do not give anti-CGRP much because majority of our patients do not afford it. So it is
Uh-huh.
like around 30,000 rupees here per month expense for erenumab, that is that anti-CGRP molecule. So 30,000 rupees will be like, I think something like $250. I'm not sure exactly how many dollars. Maybe Surya can tell us.
$250.
Yeah, 30,000.
$250.
Yeah, yeah. So around 20,000 to 30,000 rupees is the expense. So majority of our poor patients will not be able to afford it. But my colleagues in the private sector do use erenumab.
So it's
Yes.
like in Brazil, if the patient can pay, you can
Yes.
start the treatment with an anti-CGRP therapy.
Yes. 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 Exactly.
What about South America? My dear Maria Teresa Reis, Marilia Teresa Reis, what about in Peru? Can you prescribe from the beginning, if the patient can have it, an anti-CGRP monoclonal antibody?
Hello, good morning. We don't have anti-CGRP monoclonal antibody in Peru. We only have rimagepant.
You see, how amazing is this? You don't have any one of the four, but you do have a Japan, which we don't have in Brazil. Amazing. We still don't have a Japan in Brazil. That's why, thank you, Maria. Thank you very much. That's why I tell you the realities are different. We cannot compare the reality in the United States with the ones in South America, India, and Europe. For example, that's I would like to ask you, what is the percentage of MOH patients that overuse opioids that you see among your medication of patients? Can someone tell me? Because the percentage in Brazil, fortunately, is still very low. But I would like to know in other countries, what is the
Hello, sir.
percentage?
Yes, we did a study on 400 patients with migraine recently, sir. And we found only one patient with opioid overuse, just one patient. That was butorphanol. Yes.
Which is good, which is
Yes.
good. But I know that in the United States, for example, where they have Stadol, butorphanol in nasal spray, and the patients keep using that all the time, is a plague. They go to the emergency departments, they receive tramadol, which is not indicated for migraine attacks. So it's very nice to know.
Sir, I have one more question for you, sir. Uh,
Please.
do you find that people with medication overuse have more prevalent depression or anxiety as compared to patients with chronic migraine without medication overuse?
I do so. I do so. I have a colleague in São Paulo, a very good neurologist, Paulo Monzilo. Once he asked me the following question: how many patients with medication overuse headache and daily headache that you have that are happy, active, happy with their professions, well married, practice physical exercise, and have a normal life? How many? And I thought, and I said, none, zero. Every patient I have with medication overuse headache either is depressed or has anxiety and or has personality disorders, are not happy with their marriage, are not happy with their profession, are overweight, So that's why the played of clinical presentations and things together make this so challenging in terms of approaching these patients.
Sir, hello, sir. Myself, Dr. Rupa. I have a question. You said this medication overuse headache, you would prefer anti-CGRP antibodies. So how do you plan, how long you give, how do you assess what is the prognosis, the recovery? How often you ask the patient to visit, and how long you prefer to give this anti-CGRP antibodies?
Good question. Thank you. Okay, my preference is start with the withdrawal, do some kind of bridge therapy. I like to use either, depending on the class of overused medication, I start with few days with prednisone or indomethacin. This is to prevent the worsening of the headache during the first days, 5 to 7 days. Then I start at the same time an anti-CGRP monoclonal antibody. We don't have Japans in Brazil. And I start a preventive traditional pharmacological agent. I either use low dose of nortriptyline or sometimes topiramate, depending on the patient and the comorbidities. I ask the patient to come back for the first time in 2 months, and then I give 3 months, and then I give 4 months. And most of the patients ask me for how long I will have to use such an expensive treatment like the monoclonal antibody. At the beginning, 5 years ago, we were doing like 3 doses because of the pivotal studies were carried out with 3 doses. And it was much more expensive. Nowadays, the prices, at least in Brazil, went down. And what I tell the patient, you will have to use at least 6 to 12 months. Why? Because in long-term studies, we have been seeing, and it has been published, that after 6 to 12 months, some patients do have a better outcome, improve more with the time. So what I do for most of my patients, withdraw, do a bridge therapy for 5 to 7 days, start the prevention with a traditional agent and a monoclonal antibody, and ask the patient to return in 2 months. If things are going well as expected, I give 4 months. I also ask the patient, all of them, to start any kind of physical activity. If they don't like, if they don't want, if they are overweight, if they say that they have lesions or injuries, they cannot do this, I say, doesn't matter. Go and walk fast, at least 4 days a week for 45 minutes each time. That's what I do. And also, don't forget the diary, the headache diary, or the patient will tell you, well, perhaps I got better, but I'm not sure, I don't know. Perhaps yes, perhaps no. So the headache diary is very important.
Dr. Abouch, thank you for a wonderful lecture. I'd like to ask you, did you have an experience with coenzyme Q10 for preventive therapy?
Say again, Antonio. If I have experience with what?
With coenzyme Q10 as preventive therapy.
Coenzyme Q10. No, my experience is that, let's say 80% of my patients already come taking coenzyme Q10, taking magnesium, taking riboflavin, taking pyridoxine, B2, B6, taking all of those nutraceuticals. Even one that I liked a little bit in the past, petacytes hybrids, most of my patients come already taking this, and I don't see a good benefit. If you add to the current medication, if you use as well, you may see some reasonable outcomes, but I don't think they are useful, really. I really don't think coenzyme Q10 and those other nutraceuticals are good for the patients. That's my opinion.
Thank you.
Hello, sir. Again, myself, Dr. Rupa from India again. How do you treat a medication overuse headache in a pregnancy, during pregnancy, first trimester?
That's a tough question to answer. Very difficult. You know, in the past, I had bad luck, and I have the suffering of seeing patients who were being treated by me and who became pregnant, even though they were warned that during medication, regular use of medication, they could not get pregnant. And these patients, few of them, thanks God, had problems with their child. The child were born with some problem, with some anomaly that most of the times I know was not related to the medication. But for the mother, always the responsible for that anomaly, anatomical problem, will be the medication that they were taking. So I've seen, unfortunately, few cases when the patient had problems with the child, the children, the newly born children, after being treated with a medication. So what I do right now, I don't use preventives. Do you want to get pregnant? Good. I don't use prevention. What can you take during the pregnancy if you have a headache attack? Tylenol or Dipiron. We have in Brazil, Dipiron, metamizole, because those are the only ones that are considered safe. Well, of course, if the patient have a very high frequency and it's already at the second or third semester, I may use something, but most of the times I don't use anything, not even those nutraceuticals, because they are not completely, entirely safe until prospective studies are carried out to prove their safety. That's what I do. Unfortunately, it's not a good answer. It's not what everyone is expecting. There are reports, retrospective reports, that monoclonal antibodies did change the outcome of pregnancy or the newly born children, the triptans as well, but they cannot be formally indicated yet for pregnancy, for pregnant patients.
Another question, please, Dr. Abouch. What about your approach for teenagers with medication overuse headache?
Teenagers, good question. If the adolescent is older than 14, I do exactly what I do with adults. I have 5 adolescents taking monoclonal antibodies. They are doing very well, no problem. Especially if the adolescent have a body mass index that is normal. It's not very overweight or it's not very thin. If the adolescent has an average body and doesn't have any other comorbidities, I use exactly what I use of adults. If the adolescent is younger than 14 years of age, I avoid most of the things I do with adults. I use flunarizine drops. I use like 2 milligrams per day. Sometimes I use very low dose, 10 milligrams per day of antidepressants. And this being successful with most of adolescents. Yeah, I believe there is an echo. Did I answer?
Thank you, sir.
Hello, sir. I'm having a question, sir. It is Dr. Mohammad Tawfiq from India, sir. Taking caffeine will come under medication overuse headache, sir. And another one question is taking analgesic for pharyngitis, back pain, and any other issues. That also will come under medication overuse headache, sir.
Can you repeat the question slowly a little bit?
Okay, sir. Taking caffeine, plain caffeine, like 100 mg, 200 mg, plain caffeine will come under medication overuse headache. And the second question is taking analgesic for some other issues like pharyngitis, back pain, that also will come under medication overuse headache.
I'm sorry. I didn't understand. You were talking about overuse of caffeine. Overuse of caffeine.
Yes, sir.
Okay, the overuse of caffeine is a problem. Yes. Medication overuse headache is indeed a problem. We have to decrease the use of caffeine, but you have to remember that most of the medications used for headache patients have caffeine. So what I do, I limit the daily usage of caffeine to 200 milligrams per day. Just for you to have an idea. One capsule of Nespresso, an average has 60 milligrams a day. So you have to limit the daily use of caffeine to 200 milligrams a day. If you do this, the patient probably won't have any issues. But don't forget, there are patients, especially in Brazil, who take those thermogenic capsules with 200 milligrams of caffeine. They take 2 per day. They drink coffee. They drink the Brazilian Guaraná, which has caffeine. They take chocolate, tea. Some teas have caffeine. So what do you have to do? You really, indeed, have to limit the caffeine intake to 200 milligrams a day. And if you can choose a medication without caffeine, it will be better for the patient. This was, I believe, your first question. I didn't understand quite well the second question. Can you please repeat?
Okay, sir. If we'll take analgesic for other cause like pharyngitis, back pain, like etc. issues. Will it come under medication overuse headache?
You mean a non-steroidal for other causes? Is that what you asked?
Yes.
Anti-inflammatory drugs for other causes. Well, there is a very interesting study from Anish Baha from England in 2002, together with Peter Goldsby. She was studying with Peter Goldsby. She went to orthopedic clinic for mostly old people with osteoarthritic diseases. And she studied 100 consecutive patients who had to take everyday non-steroidal anti-inflammatory drugs and analgesics, because this is the treatment for some of these diseases. At the end of 3 months, a percentage of the patients, I believe it was 36, if I'm not wrong, had medication overuse headache. And among those 36, 92 or 93% of the patients had episodic migraine in the past. So, doesn't matter if the patient take non-steroidal or analgesics for other diseases, if they have a primary headache disorder, it's most likely that they will develop, after some months, medication overuse headache. The patient sometimes comes to me and say, "Doctor, I overpassed your limit of 2 days a week, but the medication was not for my headache, was for my feet, for my back, for..." Doesn't matter. If you take medications more than 10 days per month in an average in a patient with primary headache, you will develop medication overuse headache, okay? Sooner or later. And you have to educate the patient regarding this.
Sir, again, myself, Dr. Rupa, I have a question. What are the other alternative mode of therapy or the treatment for an MOH for whom CGRP cannot be given?
Say again, my dear, a little bit slow.
If there is a contraindication for the CGRP antibodies, what are the other modes of treatment for such patients?
The contraindication, which one? For example, the patient plan a pregnancy, or the patient, because I don't see too many contraindications. Mostly they cannot pay, or they are planning a pregnancy. If they are planning a pregnancy, there is contraindication of everything. Okay, even the GPANs. The GPANs are anti-CGRP therapies as well, but they are for the receptors, and they are small molecules with central penetration. Other than not being able to purchase the medication, or having another problem like planning a pregnancy, I don't see other contraindication. Unless you say, well, the patient has cancer, is treating a cancer, or is taking, even if the patient is taking another monoclonal antibody for other diseases. We've seen patients with temporal arthritis taking monoclonal antibodies. We're seeing patients with Crohn's disease taking monoclonal antibodies. But these are not contraindications to anti-CGRP monoclonal antibodies. You can use both. But if I can't use, I will choose a traditional pharmacological agent. I start, because I am in a tertiary center, I am with more complex patients. I already start a combination of therapy. I start with low dose of antidepressant, tricyclic, and low dose of flunarizine, for example. But whenever I can, whenever the patient is able to, I start anti-CGRP therapies as well.
Doctor,
What's your take on neuromodulation for MOH?
You know, the devices, right? Neuromodulation. Well,
Yes.
I didn't talk about neuromodulation devices like Cephalai and some others because we don't use this in Brazil. We had Cephalai some time ago. We have very few colleagues using transcranial magnetic stimulation, but you have to remember that these equipments are expensive because the prices are in dollars. Our money is very weak, and most of the patients do not want to pay for these therapies. The experience I had in the past when there was the beginning era, I think 1 decade ago, with Cephalai and with transcranial magnetic stimulation, the patients that I tried didn't improve. So I don't use anymore. It's a costly treatment to which most will not adhere. But I know that there are colleagues that use this.
thank you so much for your great presentation. Doctor, I have a question. I am from Peru. We don't know, we don't have CGRP inhibitors. So my question is that is how well is the use the botox y how many medications the migraine a woman or boy with migraine have to take for the and classification for we overdose of
How many
treatment.
medications are necessary to
Uh-huh.
classify the patients are overusing, right?
Yeah, right.
Good.
If how effective is in the Botox or lidocaine?
Okay. First, Botox. I don't use Botox.
Mm-hmm.
Just for you to know, I was the first one to use in Brazil during the 2000 decade when Botox was first published to episodic migraine. And I used 35 patients for free. Allergan gave me the Botox. I tried in 35 patients and none has got better. Well, but we know that it's not for episodic migraine. From 2010, 2011 on, when Botox was approved for chronic migraine, some patients that I received, that I saw, had already used Botox many times. They paid a lot of money for dishonest physicians. And Rio de Janeiro has a lot of dishonest physicians who use Botox a lot for everyone, all kinds of headaches, just with the purpose of making money. So I've seen so many patients that were not withdrawn. They didn't stop the overused medications just because they were trying to do more and more Botox to make money. I didn't see anyone improving with Botox. And I showed during my presentation a very nicely done study from Brain, 2019, Ferrari's group, who showed that if you withdraw overused medications and withdraw and use Botox, it will be the same thing. So Botox will not render any advantage to the patient. So I don't use Botox because it doesn't work. It's something for some physicians to make money. I know that Americans love Botox. They use a lot of everyone. It's not my case. It's not the example of some colleagues here. Regarding the limitations, depending on the class of the medication, if you are talking about ergots or opioids, more than 2 days per week is overuse. If you are talking about triptans or combination analgesics, more than 10 days per month is overuse. And if you are talking about simple analgesics, more than 15 days per month is overuse. Regarding blockades, some people like blockades. I don't do blockades. Sometimes in the past, I did the greater occipital nerve, the supratrochlear nerve, some other nerves. I did some blockades. But if the patient improves in a central originated neurological disease, if the patient improves, will be short term. So if you can keep doing blockades frequently every week, every 2 weeks, and the patient likes, you can do. But it will not render or provide a very long-term relief as some people want us to believe. I'm very clear-cut physician who practices what is better for the patient, not what is better for my pocket. And we have to be careful about this.
Thank you so much. It's very important that no efficacy of these injections or blockades of the pain. Botox in my country, was more. There are so much people who
I understand. What is your country?
Peru.
Peru. You are also from Peru. Everyone is making Botox, right?
Yeah, I don't
It's amazing.
understand.
No, you do understand. You do understand. Botox gives money to the doctor who uses.
I don't use Botox because the fattiness is only for 3 months or say 6 months. I in is not 1000% the pain is going. So I don't believe it.
I
But
don't believe either. I am like you. Congratulations.
yeah, it's more important that the antibody, CGRP,
Yes, sir.
anti
And it's amazing to know that in Peru, you still don't have the monoclonal antibodies. It's interesting, but
yes, because it's a
you already have
monopoly.
it.
Is more money. And because I neurology very young, and the rest are very older and told me, you don't know about that.
Amazing.
It's bad because neurologists uh, have to help another neurologist. Thank you so much. Yeah, greetings for su
It was my
for
pleasure, my dear. Thank you for being here. And I'm giving you right now in the written part the link if anyone wants to join the Brazilian Headache Symposium on August the 8th. It will be presented by many colleagues in Portuguese, in English, because Mesuda China will talk, Marco Lizik from Argentina, and some other good physicians from all over the world. The link is right there, and there will be some kind of subtitles in your language. If you request this, will be some subtitles in your language. So thank you very much, Dr. Sophia.
Sir, I'm having one last question, sir. Can I ask you, sir?
Yes, sir.
Yes, sir. Sir, patient after having anti-CGRP also, they are not finding any benefits, sir, after having 140 mg erinumab. What we should do for this, sir?
Good question. There are literature in the last 2 and 3 years showing that if you switch the monoclonal antibody, especially switching from erenumab to galcanezumab and perhaps others, 30% of the patients will start improving. So the lack of response to one monoclonal antibody anti-CGRP does not show that the patient will not respond to others. And this study was very clear. I believe it was 32% of the patients not having responded to erenumab. You can switch to another one. I prefer galcanezumab. You may have a better response through the time.
Thank you so much, Dr. Krymchantowski. And thank you everyone for the amazing questions. It was quite an intensive discussion and very nice to learn from each one of your experiences of how headache medicine is being managed in your countries. Thank you so much. And thank you so much, Dr. Abouch Krymchantowski.
It was my pleasure.
I hope we have you again over for some other topic because it's so great learning from you. You have quite an experience in the field and a lot of expertise, so it will be amazing for us to have you over again. And thank you everyone for joining on this Sunday morning. And I'll also email the link that has been sent by Dr. Krymchantowski for the symposium to all our World Headache Society course participants so they can have access to it and can join it. Thank you so much, everyone.
Thank you, everyone. Thank you, Dr. Sophia. Thank you, my friend Pravin Thomas, Dr. Pravin Thomas, who is the leader of the World Headache Society, a society that likes the merit, not the politics, the merit and the desire to learn. Thank you very much, everyone. Have a nice Sunday. Here we are starting our Sunday is 12:53. For Dr. Sophia is 1 hour behind me, and for all of you are 8 hours ahead of me. Thank you very much, everyone.
Thank you, everyone.
Bye.